you all for joining us for today's webinar, Opportunities to Engage Women's Health Through Alzheimer's Disease Policy Initiatives. I'm Katie Schubert. I'm President and CEO of the Society for Women's Health Research, and we are delighted to have you all joining us for this really important conversation during National Alzheimer's Disease Awareness Month, which is in November. Before we dive into what's going to happen today in the conversation, I just want to make a few housekeeping notes. We are recording today's event and it will be posted online. If you are going to ask a question, which we strongly encourage you to do, we would love for you to use the Q&A function at the bottom of your screen. You can use the chat function, but it's definitely better to use that Q&A function for us here. There is a live transcription feature available on the webinar, and you can access that by clicking CC Live Transcript at the bottom of your screen. And if you don't see it, you might just need to expand your window. And just to note as well, this webinar is intended to serve as an educational and informative resource and is not intended or implied to serve as a substitute for medical or professional advice. So SWHR as a whole does not make medical diagnosis or treatment recommendations, nor do we endorse or promote specific screening or diagnostic tests. And patients and consumers should always consult with their professional healthcare provider to determine individual needs. Just to give you a little bit about SWHR, we have been around for almost 35 years. We'll be celebrating our 35th anniversary next year in 2025. And we are dedicated to advancing women's health through science, policy, and education while promoting research on sex differences to optimize women's health. Our vision is to truly make women's health mainstream, and we think that that's a really important mission and vision. We're delighted to have you all joining here today to share in that mission. We also want to thank our sponsors of today's event, Eli Lilly, and Roche. Their support in our Alzheimer's disease and brain health work is really important to allowing us to provide these free and freely available opportunities for you all. So thank you for that. And as I mentioned, it is National Alzheimer's Disease Awareness Month. And as you all probably know, Alzheimer's disease is a progressive neurological disorder of the brain that affects memory, thinking, and behavior. And it's the most common form of dementia, with more than 6 million Americans living with Alzheimer's disease. And importantly, it's the fifth leading cause of death for women. I would also note that more than 60% of unpaid Alzheimer's and dementia caregivers are women. So a really critical, I think, women's health and women's issue for us to really be talking about today. I'm going to quickly introduce Ian Creamer so we can get to our conversation, who has graciously agreed to moderate today's discussion. Ian is the Executive Director of the LEAD Coalition, and I think this is really going to be a thoughtful conversation with our panelists, who are fantastic, to really explore topics related to Alzheimer's disease and other forms of dementia and policy, and more specifically blood biomarkers and the CMS guide model, which I'm thrilled to have you all learn more about. And note that the LEAD Coalition works collaboratively through federal public policy to improve quality of life for all people facing dementia, while advancing the social and biomedical sciences to prevent, treat, and ultimately cure all forms of dementia. So Ian, I am going to turn it over to you to get this conversation going. Thanks for being here.
Thank you, Katie. Always a pleasure to work with the Society and with you and your team. It's wonderful to have this opportunity to talk with around women's health and Alzheimer's disease issues with Dr. Cara Levy from Memorial Health Institute for Neuroscience and Tanya Saffer from the Center for Medicare and Medicaid Services Innovation Center, which our audience will probably hear us refer to as CMMI a few times today. And with that, I just want to take a moment and ask Cara first, if you would just please briefly introduce yourself, and then we'll turn to Tanya.
Yes, hello. I am the Director of Cognitive Disorders at Memorial Healthcare, which is a hospital-based community neurology practice in the middle of Michigan. I'm a full-time clinical neurologist, which means I see patients with Alzheimer's disease on a full-time basis.
Thank you. And Tanya, over to you.
Hi, Tanya Saffer. As Ian said, I am a division director within the CMS Innovation Center, and my division develops models and initiatives that help people with chronic and serious illness remain in their homes and communities. So delighted to be here on behalf of the team that is producing the Guiding and Improved Dementia Experience model.
Thank you, Tanya. Kara, let's start with a few questions for you about using diagnostic testing, and particularly the use of blood biomarkers in that work. So recent advances in blood biomarkers for Alzheimer's disease have been exciting. I think we've all read a lot about that. Can you tell us a little bit about how these blood biomarker tests are changing the ways that practicing physicians, neurologists in particular, are approaching diagnosis, and what are some of the current limitations or challenges in their adoption?
Yeah, so as I mentioned, I'm a clinical neurologist, so I'm evaluating patients who are coming into the office with concerns about their memory, and then seeing them through a determination of what treatments are best for Alzheimer's disease. About 2 to 3 times a day, I'm now ordering blood-based biomarkers, and I'm mainly using them, as many of my neurologist colleagues are, and that is mainly as a screening tool. So it helps me to think, as I like to say, think Alzheimer's early, when those initial tests we're ordering to determine what might be causing the memory issues, when we might be getting neuroimaging or other labs, to be thinking about if we want to add that screening tool so that we're moving to that diagnosis more quickly. One of the problems that we're having with that is that it's a little bit, it's harder to do that because whenever I'm ordering this testing, I'm having patients fill out a financial assistance online application before we're able to draw the blood-based biomarker, because we don't have reimbursement from payers for any of these blood-based biomarkers. So there's some extra time just at each time I want to order those to make sure that it's going to be something that's financially feasible for patients. In addition to that, I think that it's when we're thinking about some of these new therapies for Alzheimer's that have come out in the last couple of years, one of the things that's important to identify the right patients for these therapies is to know if they have the target for these medications, which is amyloid. And we have been using an imaging test called an amyloid PET scan and sometimes spinal fluid analysis to confirm they have that target. And in the future, the way to expand access for these amyloid-targeted therapies is to be able to use these blood-based biomarkers for diagnosis, for what we call amyloid confirmation, to make sure that everybody can have access to those therapies.
So it sounds like part of the issue is making sure that both public and private payers set up policies around reimbursement for these tests, and then also working with patients who may not currently be able to afford the tests, and that can present a health equity challenge. Both, and I guess also as a clinician, just a care challenge, because we all know that women tend to be diagnosed later than men, have somewhat different warning signs and intensity of warning signs. So I gather, just as a practicing clinician, looking out for the best interests of your patients, having a test that patients are more used to getting, a blood draw, is much more accessible, less challenging in terms of patient education than talking about a more expensive, more cumbersome spinal tap or PET imaging study. Would that?
Absolutely. And I think that, yeah, absolutely. And what I've seen in my own practice in ordering these tests, I think now we've ordered maybe 300 in the last year and a half. What I have found in my own practice is it does make me think Alzheimer's early when I'm initially evaluating, and it makes me also think Alzheimer's too. So just because someone has a potentially additional explanation for their cognitive symptoms, they could also have Alzheimer's. So we're not necessarily looking for just one cause of their symptoms. We can look for copathology and an additional reason. So for instance, someone who's not compliant with their CPAP for sleep apnea, they could also have Alzheimer's. So it really does expand the way we think about who should be tested, who we should be screening in that way. And you're right, patients are much more likely to say, okay, I'll add that blood test if I'm already going to get a blood draw for some other things. Yeah.
Right. And to your point about access, using blood tests also probably makes it easier for specialists like yourself to partner with primary care that are more familiar with and comfortable ordering blood tests than they, and maybe have more authority to order blood tests than they might for PET imaging or spinal taps.
Yes, I think that's where we see this going, is that eventually we're having the screening kind of testing done at the primary care level. And what got me interested in starting to use them in my own practices is that I want to know how to use them, in what ways they are helpful and what ways they're not, before they are as mainstream as we know that they're going to be, so that I can help educate those primary care referring physicians on what the best use for it are as well.
So I want to stick with this theme of ensuring accessibility. And again, particularly thinking about women who, we know women generally face a lot of health system barriers, but particularly when we're thinking intersectionally, women who may live in medically underserved communities or have other challenges accessing the healthcare system. Are there other things that the health systems themselves need to do, or that practicing physicians need to do to make these blood biomarker tests for Alzheimer's more accessible and, to your point, available earlier in the disease process to patients, particularly female patients?
Yeah, what we know is that the way that we are confirming a diagnosis of Alzheimer's disease now has its limits. And amyloid PET imaging centers, for instance, are not everywhere. And in my area, people have to travel about 2 hours to get to an amyloid imaging center. And that is a big barrier in itself for people to go, especially who are becoming more elderly, to travel for these kind of diagnostic tests. So it also improves the number of people who would be willing to even be tested for it initially. The other thing with Alzheimer's disease is that patients themselves can sometimes have pretty low insight into their own difficulties, and sometimes they just deny that they're having any memory problems at all. And it's a way to kind of introduce this idea of potentially an Alzheimer's diagnosis, is to say, well, let's screen for this. And if it comes back positive, we could do another test to confirm. They would say, a lot of times they'll say, fine, I'll be screened for that, where I know it's going to end up being positive. And it's a way to then get to that diagnosis that they might be resistant to even doing the testing if it was something that was took a little more time.
Got it. And so really fascinated about this idea also of the transition to treatment. And we know that not everyone who tests positive for amyloid protein will be eligible for treatments, but can you talk about the role of these tests in, again, opening that conversation, but also making joint decisions with your patients about the potential for the new disease-modifying treatments?
Yeah, I think one of the things when we have all these new medications that have come out in the market, and we're talking about treatment so much, that sometimes we forget about how there is really value in just having a clear diagnosis at any stage of the disease. That has been historically difficult and has been not accomplished accurately or not at all for people who have dementia in the past, as we know. So blood tests sometimes are just to confirm a clinical suspicion that we may have as neurologists, and might not lead to starting some of these amyloid targeted therapies. And I still think that's valuable. But in the scenario of getting patients that earlier diagnosis and then moving to these therapies, these are going to be absolutely key. And what I find is that in my own experience, they have been as accurate as amyloid PET imaging. For instance, we've determined that about 95% of our amyloid PET scans then that I ordered are positive. And that's because these people have already been screened with a blood-based biomarker, which helps to reduce some of the strains on imaging centers that are now have longer and longer wait times to get an amyloid PET scan, when we already know that the pre-screening has already been completed. It's a high probability that that's going to come back positive. That being said, we're also limited in being able to just use this as the amyloid confirmation test and not having to do the amyloid PET scan at all in cases where the clinical suspicion is very high for Alzheimer's in the first place. And that is a step that I think as we all become more comfortable and the data continues to show that these biomarkers are accurate as amyloid PET imaging, I hope that we see them as equivocal kind of diagnostic tests. And that's when we're really going to be getting good at moving patients from that early diagnosis onto therapy as quickly as possible.
So I want to make sure I'm following this. It sounds like it's also a way to reduce health system expense. If you're able to use hypothetical scenario, you get a patient who comes back negative on one of these blood biomarker tests, high validity test that you have strong confidence in, that's been validated appropriately. It may negate the need for a more expensive, more patient burdensome, more healthcare system intensive PET study. Is that correct?
Correct. And if it comes back negative, I'm looking for other causes, and I may circle back to the idea of Alzheimer's if it feels like clinically this continues to look like Alzheimer's, and perhaps even repeat the blood-based biomarker at that point. But what I have found is that they're very helpful because they are very accurate. In fact, a few of the times result confirmed with an amyloid PET scan at our local academic center, I have found that occasionally the PET scan will be negative, but the blood-based biomarker was positive. I've asked both of them to take another look at the case, and in 2 of those cases, it was actually the amyloid PET reading that was changed, and the blood-based biomarker ended up being the most accurate test. That is in part because amyloid PET scans, it is a visual read in most of these places. So they are only as good as the radiologist and the experience of the radiologist of those who are reading these scans. This hasn't been really factored in when we talk about the accuracy of amyloid PET scans. This is from data of research studies of radiologists who have been trained and have been working in trials for a long time who are reading these things.
Got it. And Tanya, I know you wanted to jump in, so the floor is yours.
Thanks. I just had a question for you, Kara. Going back to something you said earlier, you said that one of the reasons you wanted to use the blood-based biomarkers test early was to get a sense of how, I think you were saying, how to communicate use of this to a primary care clinician. I was just wondering, do you think we're at the point where primary care clinicians can assess what these tests mean and communicate the results appropriately to somebody that may have Alzheimer's? I just want to dig in a little bit more about what you were inferring there.
When we bring this to primary care, which is where these tests are going to eventually go, when that is, we don't exactly know, but when it does, it has to come with the education piece to this. There needs to be a big effort to educate primary care doctors as to not just when to order the test and maybe when not to, but what Alzheimer's is, why we need an early diagnosis, how are we even diagnosing Alzheimer's? Because I get primary care doctors that still are clinging to those 1980s criteria where we need to do this, we only can diagnose it on autopsy. So there are some of this just full of misinformation and misunderstanding of this diagnosis. So I do have confidence in primary care. I think they will be able to use these blood-based biomarkers. They use similar kinds of tests for other types of diagnoses, but it has to come with that support in better understanding of the disease process, better support from the specialists, from the neurologists to be able to help them interpret these results, because sometimes they aren't clear. Sometimes they are in that indeterminate range, and those are tougher cases. So that support and education is going to be key to helping them be as successful as I think they can be.
It's a real opportunity for collaborative team-based medicine, both within an extended practice and maybe across practices where specialists are working hand in hand with primary care to understand how to use the tests, what they mean, how to discuss them with patients and families, how to discuss them with other medical professionals.
Yeah, and I don't think we always easily do that. Primary cares might say, well, it's hard to get a specialist on the phone. We do need to come up with a system where we can have more of that, as you said, kind of a collaborative kind of team approach for this, because it really is a team effort to get people diagnosed early with Alzheimer's and to be able to access options for new treatment. It is from the first time they mention memory decisions for the treatment that's right for them.
Great. And so as we're thinking about the policy perspective on this, are there things that policymakers can do at the federal level, state, or even local level in terms of, at the federal level, say reimbursement structures for physicians, or at the state or local level, are there things around public health initiatives, development of practice guidelines, et cetera, where policymakers can have a role, either payer agencies, regulatory agencies, funders?
Yeah.
Are there roles for policymakers in helping get these blood biomarkers to be more accessible to clinicians, help clinicians develop best practices for when and how to use them on behalf of their patients?
I mean, more or less all of those things we need. We don't have access. They're not always available in certain areas. When they are, they're not reimbursed by insurance. So as I mentioned before, most people are paying out of pocket for these tests. They can be very expensive if there isn't a financial assistance program set in place. That we need to have guidelines for how to use them. Absolutely. The Alzheimer's Association, working with other sources, will have more confidence that they're using them correctly. One of the things that's the hardest with talking to patients right now in Alzheimer's disease, diagnostic and treatment, is that I can't guarantee that their payer will pay for the testing that I know we need to order. I can't guarantee that their payer will pay for the new therapies that they've brought the article to show me and they're all excited about. I cannot guarantee that. And that's what makes a tough day for me, is that I don't know if I will have access, and equal access, therefore, for every patient to be able to get them the same accurate diagnosis, the same options for treatment.
And I gather, and you would obviously know much more about this than me as a practicing physician who uses all sorts of tests on a regular basis, but I gather it's not just that Medicare and private insurers ought to cover these tests, again, the appropriately validated tests, but they have to reimburse at an appropriate level so that the physician can order them with confidence that a local lab is going to be willing and able, based on the reimbursement they get, to run that test.
Yeah, and that is true on with blood-based biomarkers, and it goes for diagnostic testing. It goes for amyloid targeted therapies. That there has been reluctance, at least in Michigan, to offer these either diagnostic tests or therapies because they don't know what that margin is going to be, or if they're just going to lose money, which is a concern in itself. And when we're talking about the sheer number of patients that could potentially benefit from these diagnostic tests and the treatments, even losing small amounts of money on that number of patients is a concern. And I'm very lucky with my health system that has taken this on. We see it as a responsibility to our community that we offer these tests. Center feels that way. Not every health center has the ability to absorb some of the costs right now.
And I gather you may have to run a test more than once in a patient's lifetime. They might be amyloid negative, not have the amyloid protein present in sufficient levels to define it as Alzheimer's disease at one point in life, and then 5 years later you might need to retest them and they might test positive.
Yeah, what we were hoping in time is that blood-based biomarkers are going to be able to quantify how much amyloid or how much tau is present in the brain. This is the hope, which will also be helpful then for tracking of how treatments are working or not working to help with treatment decisions. But also from the diagnostic purposes as well. So this is our hope as we look into the future, is that they're not only a screening or even a diagnostic test, but a prognostic test that we can use and test during treatment to understand how that treatment is working in our patients.
So, Kara, one more question for you at this point. If we had NIH and the Centers for Disease Control and the Food and Drug Administration on this webinar, I'm not sure if we do or don't, but if you had their ear for a moment, what would you tell them is the most important thing any or all of them could do to help drive accessibility for clinicians and their patients to have the ability to use these blood biomarkers to get at better answers about the presence or absence of Alzheimer's disease?
Yeah, I think that there's a gap right now between what we're seeing in research and what we're seeing as exciting evidence that these blood-based biomarkers are accurate and do provide us additional information for our patients. And then this gap between the research and people's reluctance to begin using these in clinical practice. And approval of these blood-based biomarkers, that would be a big step in getting more people to and increase the uptake of them. In the same way that we need to push or guarantee that anyone who wants to be tested or screened for Alzheimer's can be screened for that test. To have out-of-pocket expenses for something that is so important as the diagnosis of a terminal progressive illness for which we now have treatments that can slow it down, and to not have access to that diagnostic test is wrong. And we've got to make sure that every person has the ability to be diagnosed. That is not the case right now because of payer and reimbursement issues.
Tara, thank you so much. I think we've got hundreds of additional questions for you in mind, so we'll have another conversation another time. But I want to bring Tanya back into the conversation now and talk a bit about a wonderful, exciting new program that CMMI has launched, the GUIDE model that we've referred to briefly before, which is an opportunity for people that already have a diagnosis of dementia or whose clinician can attest that they have dementia to receive more coordinated care. So Tanya, if you could just walk us through how the GUIDE model aims to address the challenges faced by people with dementia, and especially in terms of that coordination of care and support for family care partners.
Yeah, happy to. Thank you, Ian. And thanks, Tara, for the insights regarding innovation and identifying, detecting Alzheimer's disease. Millions of families are seeking that new cure and new treatments, and it's positive to see that there is a lot of progress being made and still recognizing the access barriers. CMS has helped to ensure that those with Alzheimer's have access to the new treatments that may slow or delay symptoms of the disease, while also continuing to collect data on how well these new medications are working as part of patients' care. However, while these drugs may slow progression, they aren't a cure and they can't reverse Alzheimer's nor treat related dementias currently. So other things in our healthcare system have to change to address the goals and needs that people living with dementia have. And so I'm happy to talk to you about what else we are doing through the CMS Innovation Center to try to address this. And so people living with dementia, we know they desire to retain their agency, autonomy, and independent living for as long as possible. Their unpaid or family caregivers provide a key role in helping them to do this. However, the fragmentation of the healthcare system and the disconnect of clinical care from behavioral and psychological care and from social support often makes it difficult for caregivers and people living with dementia to achieve that goal. As Ian mentioned, as cognition declines, and Kara mentioned as well, it becomes increasingly challenging to maintain physical and mental health while also managing multiple chronic conditions. 95% of people living with dementia have more than one additional chronic condition, and often the clinicians treating those chronic conditions don't have the time or the training to help patients overcome the challenges that they have in managing their health. So really underscoring what Kara said is that there's a big need for education, not just in the tests available, but overall on the disease state still. In recognizing these difficulties that both patients and caregivers have had in navigating the health system and also finding the supports that they need, the CMS Innovation Center launched the GUIDE model on July 1st, as Ian mentioned, and GUIDE stands for Guiding an Improved Dementia Experience. GUIDE will test if providing Medicare payment for a comprehensive package of care coordination, caregiver support, and respite services will achieve our three main goals of improving people living with dementia's quality of life, reducing stress and strain on their caregivers, and helping people with dementia remain in their homes and communities as long as possible. The model test will run for 8 years, and we launched the model with 390 providers, collectively planning to deliver comprehensive dementia care to nearly 200,000 people enrolled in traditional Medicare, also known as fee-for-service, and across all 50 states. So if we are successful in this model test, we hope to expand it to all comprehensive care dementia programs and reach the millions who need this care.
Great. And as Katie referenced earlier, we know that disproportionately women have Alzheimer's disease and are the primary, not only always the only care partner, but the primary care partners. So part of why I was so excited about Guide when it was launched last year and announced almost a year before that is because it's one tool toward trying to redress some of the health inequities around Alzheimer's disease and related forms of dementia. And I wonder if you could just bring us home a little bit about how inclusive the program is and what it's doing to make sure that particularly those who suffer from health disparities are served most appropriately under the Guide model, whether that's by region, whether it's socioeconomic status, biological sex, gender, etc.
Yes, that's a great question. And so we are in the Guide model collecting health-related social needs as one piece of the Guide model, but really a health equity strategy has been woven throughout the model. So there's a per member per month or per beneficiary per month type payment that we call the dementia care management payment that is paid to providers under the Guide model. That's adjusted by a health equity adjustment. And how do we identify health equity? Is we are looking at both the area deprivation index, so the status, for lack of better terminology, sort of the economic status of where somebody might live, as well as their individual factors, such as low income, whether they're eligible for a low income subsidy under the Medicare program, or they are dually eligible for both Medicare and Medicaid. That informs whether or not a provider will have an upward adjustment in their dementia care management payment for serving a high portion of beneficiaries that meet those criteria of both living in a low ADI area as well as having low income. And, or it will, if you're not, the idea is like to shift resources over to those communities that are serving a higher proportion. And so some may have a downward adjustment, others may have a neutral adjustment, and the whole adjustment is meant to be budget neutral. But that's really the goal, is to kind of shift more resources to the communities and areas where we know they have higher needs. The other reason we screen for HRSN is that in the Guide model, we're working to help people connect to social supports through community-based organizations. Some people may need transportation to get to their medical appointments. Some people may need food delivery and meals. And so connection to community-based services is a critical part of this model. And as you started to mention, a lot of women are caregivers, right? And so this role of navigating the complexity of both the medical care needs that somebody with dementia might have, because they have more than dementia, and also navigating the healthcare system while also navigating the social support system is exhausting, right? That's a lot to put on any one person. And so it can be really challenging for caregivers that are trying to help their loved ones with dementia get all of the supports that they need. And so within Guide, we are offering a number of ways to help reduce that complexity and that burden placed on the caregiver by providing care navigation services in Guide that will help people better coordinate care across the healthcare system, but also across social support system.
And if I understand correctly, the care navigation benefit for Medicare patients and their care partners, that's available 24/7, 365. That's one of the requirements of the program, correct?
One of the requirements of the program, yes, is that there be somebody, it may not be the care navigator, but that there be somebody on the care team or somebody partnered with the care team to provide 24/7 support. So if somebody, we hear a lot that as you advance into stages of dementia, and particularly in the evening, there may be wandering people getting out of bed and not, being a little confused and not knowing where they are and may leave the home. And oftentimes a caregiver that hasn't been trained or to manage that type of situation can find themselves really lost and needing to call somebody in the middle of the night. And so that's one of the reasons we have that access to 24-hour care.
So a big theme for all of us in this work is the strain on family care partners. You referenced this earlier. They're expected to be experts when they haven't necessarily had the opportunity to learn to be experts. But it's also just there's a famous book in our world called The 36-Hour Day. It's the relentlessness of the responsibility that comes, particularly as the disease progresses. And one of the things we have known for all 28 years that I've been in this work, and certainly before that as well, is that respite can be one of the central tools to help caregivers sustain caregiving and look out for their own health. And I wonder if you could just take a moment and talk a bit about the respite benefit that's part of the guide model.
Yeah, I'm very happy to. I think this is a really exciting part of the guide model and one that we're all very proud to offer and is very unique to be covered in the Medicare program outside of the hospice benefit. So Guide's respite services are intended to ensure that people living with moderate to severe dementia get the support they need, while also offering their caregivers the opportunity to take a break from caring for that loved one with dementia in order to tend to their own self-care or other responsibilities. Women, as we mentioned, are more likely to be caring for someone with dementia. And over the past decade, a phenomenon that most of us in middle age are experiencing is what it's like to be known as the sandwich generation, where we're taking care of our kids and our aging parents, often while also holding a full-time job. And it's incredibly exhausting, emotionally and financially difficult. There's also research that indicates it has an impact on our physical and mental health. Spouses who are also often the caregiver to their loved one or the primary caregiver to their loved one with dementia. And for couples who are both enrolled in Medicare, we're actually hoping to evaluate the impact that offering respite services through the guide model has on the caregiver who is also enrolled in Medicare. So great research and insights happening as part of this model as well. For the person living with dementia, the role that the caregiver has in supporting them to be able to continue living in their home is invaluable. But they can, the person, with dementia can also often feel a lot of guilt for needing them. And we believe that respite services and guide will be one of the key drivers that reduce the stress and strain on caregivers and helps that beneficiary remain in their home. And so I think it's both for the benefit of the beneficiary that we're able to offer these respite services as well as to the caregiver.
Thank you. It's going to be really exciting to see how this changes the lives of a lot of families and people living with dementia, to have that break and to have a restored and hopefully refreshed care partner able to go back in for the next day and day in, day out to have those breaks. Are there other elements of the guide model that you think help it fit into the broader landscape of Alzheimer's disease and related disorders policy? Kind of wondering what could be the next steps for expanding or refining this model as we move forward, as you accumulate evidence over the next 8 years.
Yeah, I think that's a great question. And I will say there's one of the great benefits of the CMS Innovation Center is our ability to make tweaks to the model should we identify things are possibly not going as expected. And with innovation, you're by definition trying something new. And we fully recognize that, we have done careful research and there's been a lot of past success in this space. But we did, and we did design the model to be really based on that evidence that is out there. However, it was still limited, and we know that we may see, some unintended consequences along the way in this model. So with the flexibility that we have, that Congress gave us, we have the ability to refine and as we go along over the next 8 years. So I would say, where do I see it fitting into the broader landscape? So within 8 years, why is 8 years an important outcome? Some of you may be wondering that, is that this is an 8-year model test. However, under our authority as CMS Innovation Center, we have the ability to expand or have the ability to end models early if they are not achieving their goals. With this one, we are really pushing for ability to expand. And that's one of the reasons it's an 8-year test, is that we think it could take us that long to really identify the cost reductions, particularly in long-term nursing home placement. And I would say too that as we think through what we'll learn over the 8 years, every year we publish, so starting in 2026, an evaluation report on how we are doing and progressing towards our goals. And those are publicly available. And they're not just, hey, here's how you're progressing to your goals, but there's a lot of meat and a lot of insights in those evaluation reports that I think can be used and leveraged to improve Alzheimer's and dementia care across the board, right? Even if you're not participating in the guide model, but you're just wanting to learn to better take care of your patients that have Alzheimer's disease or related dementia, there are a lot of insights there on what's working and what's not.
So for those of us that are not as intimately familiar with the working details of the guide model, as certainly you and your CMMI colleagues would be, what are things that those of us who are Medicare beneficiaries or advocates, clinicians, people living with dementia, what can all of us be doing to contribute to ensuring that you have the evidence you need to potentially, at a CMS level, make this a full standard Medicare benefit for all beneficiaries beyond the 200,000 that you hope to serve over the next years? How can we help you get to that point where the evidence allows this to be available for everyone living with dementia across the country?
That's a great question. And I think what is most important, and what I would say is a great call to action, is spreading the word that these programs are available. I still think that broadly, there's not a lot of recognition that this is a new, Medicare covered benefit that's being tested. And we have our website, and somebody could pop that in chat, or I can pop it in the chat in a minute here. That lists all the guide programs that are offering services and when they're offering services. So we have about a third program started offering services on July 1 of this year, and the rest of the 2/3 will begin delivering services under the guide model on July 1 of next year. All of that information, who those programs are, when they're delivering services, how you can contact them, are available on the CMS Innovation website. It looks like they did pop that into the chat. So that would be my call for how we can actually make sure we get to the evidence we needed, is we've got to get people enrolled in the programs.
Right. And then presumably for people, Medicare beneficiaries and their families, give feedback to the providers, the healthcare providers, about whether it's meeting their needs or not, and help them get better at what they do for all of us.
Absolutely. And I'll say one more thing. It's also open enrollment season for Medicare. And so for those considering staying in traditional Medicare or considering newly enrolling in Medicare Advantage plans, they may want to ask too what benefits their plans are offering for comprehensive dementia care, as the guide program is only offered to those in traditional Medicare. So learning if you're thinking about going into Medicare Advantage, learning how they're covering comprehensive dementia care like guide is really important.
Terrific. Well, before we turn to our audience for their questions, I just want to give each of you an opportunity to give us maybe one key takeaway that you'd like our audience to hear from you around the intersection of policy and Alzheimer's disease and related disorders, particularly with that focus on women's health. And Kara, why don't we go to you first for this?
Yeah, so I think the takeaway is that we, as some of the behavioral neurologists in the country, are already using blood-based biomarkers effectively, mainly as a screening test. And the limits to our screening and our use in them is mainly around reimbursement and the idea that we need payers to recognize blood-based biomarkers as a way to diagnose and confirm amyloid. We know that women are diagnosed earlier with Alzheimer's disease. This is a way to screen people early on when they're having just mild symptoms. And it can be a part of the initial evaluation from a neurologist or, at hope in time, the primary care doctor.
Terrific. And Tanya, a closing thought from you. What's your big takeaway for women's health and Alzheimer's disease, particularly with an eye toward policy?
Yeah, I think as Katie pointed out, and we've said a couple times, women are just proportionally impacted by both having the disease as well as, living, providing, serving, as a caregiver. So delivering longitudinal comprehensive care to people living with dementia and supporting those caregivers is critical investment for our federally funded healthcare programs. And if successful, will pay for itself through reductions in federal and state spending on institutional care. However, it's not possible without the support of caregivers and without caregivers investing in their self-care. So that's sort of my key takeaway, is that self-care and caregiver support is really critical for making sure that we are providing the best ultimate care we can for our people living with dementia.
Terrific. Thank you both so much. I learned a lot. I'm sure our audience did as well. And we've got about another, I think, almost 9 minutes for questions from our audience. So if anyone in the audience would like to submit questions, I've got a couple already that I can share, but keep them coming in. And so Tanya, one question that's come up that I want to bring back to you is just about what it takes for someone who is in Medicare and traditional fee-for-service Medicare to be able to begin receiving services. Obviously, they have to have a healthcare provider who's already delivering services through the guide model, who's signed up with CMS to do that. As I understand it, the doctor initially, or the medical team, just has to attest that the person has dementia, but then they're going to need, the healthcare providers going to need to follow up with a confirmed diagnosis. Is that correct?
Yeah, that's right. And I think even if they don't have a healthcare provider participating in a guide now, they are able to look on our website, reach out, contact a new provider that's providing or participating in this program. But yes, in order to start in the guide model, all that's needed is an attestation from a guide clinician that they have dementia. And then that is before the provider can get paid for services, there would need to be a follow-up to confirm dementia diagnosis. And that's done through a comprehensive assessment that we have a form that providers fill out, but providers can use a couple different tools to do both an assessment of cognitive function as well as physical function. That results in a score on those assessment forms that we then use to help us understand the intensity of the dementia or the severity of the dementia. And then we'll also, if a person living with dementia has a caregiver, we will also ask the provider to assess the caregiver stress and strain. And so the combination of that, the scores on that assessment with the patient assessment, puts them into a tier that indicates to the providers or the intensity and level of service that they're going to need.
And can a blood-based biomarker be part of the documentation of a confirmed diagnosis? I know the biomarker right now would just define Alzheimer's disease, not other forms, but is that part of the package a physician could submit?
I think what a physician would submit at this point is a diagnosis code, right? So whatever is used that a clinician chooses to use to diagnose officially dementia or type of dementia, that is all they would need to do in order to provide that confirmed diagnosis.
Oh, thank you. And Dr. Leahy, we have another question that's come in for you. So I apologize, I'll read it for the first time here. Is Dr. Leahy defining screening as performing these tests on people without symptoms, for i.e. breast cancer screening with mammography, or are you referring to screening in people who are already showing some signs of cognitive symptoms?
Yeah, so these are people who have been referred to a neurologist because either they have had concerns themselves and sometimes have asked to see a neurologist for their test through their Medicare wellness screen has identified that they're having some issues or that they had an abnormal cognitive test at their level. So I very rarely are seeing people for concerns about a preclinical asymptomatic Alzheimer's disease state. In a neurologist's office, these would be people that would be already reporting symptoms. And for me to be screening for Alzheimer's have also shown at that visit to have an abnormal cognitive test.
Thank you. And I will just add in it moderator's prerogative. I can tell you as a non-scientist, non-clinician, that at every turn, what I have seen from the research community that's developing these blood biomarkers, academic researchers primarily, is that the appropriate use recommendations they're issuing are to not use blood biomarker tests at this stage for asymptomatic individuals, that you really are looking to use them as a way of chasing down what symptoms are presenting themselves, being reported by the individual, by family members, being observed by clinicians. So it all fits beautifully with what you laid out about how you practice. So we have another question that I'll bring in from our Q&A function. Can you speak to the gap in housing and housing placement and accessibility once a diagnosis of Alzheimer's is rendered? I, presumably another physician, I have numerous patients who don't want the diagnosis, and that's in quotes, don't want the diagnosis, due to fears of losing their entry to end-of-life housing. I see a social reckoning coming with the gap in science and clinical care along with social policy. So I think what the person is asking is how to counsel patients who may be anxious about whether or not to pursue a diagnosis because they worry about the collateral consequences of a diagnosis of dementia being in their medical record, whether that's for housing, long-term care insurance, perhaps driving privileges, other issues. And Dr. Leahy, I wonder if you could kind of walk us through how do you advise patients to weigh those considerations against the value of knowing what they're facing and not knowing what they're facing?
You know, I think most of the time when patients are coming to see me, they're very concerned. That's why they're there. They wait months for an appointment to see me, and they want an answer. They want an answer to why they're changing and why they're not able to do the things that they have. That is, you know, I think that the thing that's pushing them toward wanting to get some additional testing. I do run into sometimes, especially with the genetic testing and talking about how that might play and who can see the records and who cannot. And I think that there is some of that, again, with that low insight into maybe they're thinking that they're not really having issues, so why would they want to get tested? That kind of plays a role into it. But more or less, at least when people are coming to see me, it's because they want answers. They want an explanation. And they are concerned a lot of times about having Alzheimer's disease, oftentimes maybe have a family member who's had Alzheimer's disease. Now are coming in too because they have heard that there might be some medications to slow this down and maintain where they are right now for a longer period of time. So I don't necessarily I certainly hear testing, but of not the diagnosis itself playing a role into, like, for instance, housing issues. I haven't heard that from patients.
And I will again just offer, since I come from the policy world, I'll say if there are areas where people with a diagnosis are facing discrimination, we have to fight that discrimination and get better laws and better enforcement of existing laws to protect people from discrimination, rather than asking people to forego a diagnosis or hide any sort of health condition. We want people to be able to live as openly with Alzheimer's disease and other disorders as many people, I won't say all people, but as many people are able to live openly with a diagnosis of cancer, HIV/AIDS, emphysema, you name it. There shouldn't be discrimination. We'll all work together on that. So let's do one last question for Tanya, and then I'll turn things back to Katie. Tanya, can you just talk about, in the context of the GUIDE model and the GUIDE program, where in the progression of Alzheimer's disease or related disorders do people have to be to qualify for services?
Yeah, that's That's an important point. So, at any stage of actual dementia, right? So, any mild, moderate, or severe, any type of dementia, it's pretty inclusive definition, but there does need to be that diagnosis of dementia that follows the attestation. So, things like mild cognitive impairment would not qualify for the guide model.
Right. And so by extension, if someone is asymptomatic, they maybe have evidence of a predisposition to dementia, but they don't have dementia. They don't have any cognitive symptoms that are abnormal. They're not eligible either. You have to have active dementia, as you said, mild, moderate, or severe.
Correct.
And as I understand it, the range of the extent of reimbursement for the physician based on the intensity of services goes up under the guide model with each progressive stage of dementia.
That's correct. Yes.
Okay. Perfect. Well, thank you. I just want to give enormous thanks to both Tanya and Kara and remind everyone to follow that link to the guide model. Really rich website full of very user-friendly resources about what this is, how it works, who it's for, and how we can all spread the word to get more people the sorts of supports that we all deserve and need. And with that, it is my pleasure to turn things back to Katie, and thank you again to our audience for indulging us in this conversation. Katie, over to you.
Thank you, Ian. Thank you all so much, Kara and Tanya. Your expertise and in your explanations of all of this is so helpful. And I know just based on the conversation we see happening in Q&A, it's really, really important for us to continue to have this conversation. And so we really appreciate you taking the time to do this. And Ian, excellent job. Thank you for agreeing to moderate for us. As mentioned before, we will post this webinar online. You'll get an email when it is ready, and please feel free to share it with anyone you think might be interested in hearing more about this. We also encourage you all to just stay connected with us. We have a lot coming up in the new year. It's a new year, there's a new Congress. We are planning on a congressional briefing and really bringing the message surrounding Alzheimer's disease and related dementias in women to Capitol Hill to be talking more about what we think they could be doing to support this community in particular. And again, follow us on all the social media channels. Thank you for taking the time today to spend this time with us to celebrate National Alzheimer's Disease Awareness Month, but also to learn more about these really important initiatives and ongoing work here. So thank you all and have a great day.